The problem we have is that many physicians treat the symptom and not the disease. So you have pain of any type, they're treated with an opioid. In migraine, there are very specific treatments for headache. I'm not saying that opioids are always wrong and always evil, but in patients who take lots of opioids for the treatment of migraine, they frequently wind up with more frequent and more severe headache. And the worst part is when you stop them, their headaches don't always get better. The other major issue we have with opioids is people, and a lot of them, how do we detoxify them? It can be, sometimes patients have to be admitted for detoxification, other times they have to be slowly tapered off of it and carefully monitored, realizing that during the taper, their headaches could get worse. The evidence strongly suggests that opioids are not as effective as drugs like triptans or even nonsteroidals for headache, but that doesn't mean we should never use them. There are times when that may be your only choice. In general, if you have a severe headache, an occasional severe headache, and you're elderly, you may not be able to take a nonsteroidal or a triptan. It's not unreasonable to use it on an occasional basis. If you're pregnant, sometimes the only thing that you can safely take would be an occasional opioid. But again, if you take too much during pregnancy, you wind up with an addicted child. So the limited use of opioids under certain circumstances is not unreasonable. There was a recent study showing that if you go to the emergency room, the majority of patients will get an opioid, which is not the way to treat somebody with migraine. There's a lack of education in how to treat migraine, and there's been a disconnect between taking care of patients with migraine and how they're taking care of the emergency room. In the old days, we actually educated emergency care physicians. We don't do that anymore. If a patient comes into the emergency department with a severe headache, and you think it might be bad, like a subarachnoid hemorrhage or meningitis, and you're not sure of the diagnosis, under those circumstances, I have absolutely no problem giving an opioid. If you have migraine, which is diagnosed, and you're elderly, and you cannot take a triptan because of cardiovascular problems or nonsteroidal because of gastrointestinal complication, it might not be unreasonable to use an occasional opioid. And the third time might be a woman who's pregnant with intractable headache, an occasional opioid might be something I might use. I think the problem we have with the opioid crisis is people are looking at symptoms and not the disease. Why are patients getting opioids? They're getting opioids because pain became the vital sign, and people were treating the symptom and not the disease. We need to focus on what's causing the pain and treat that, not simply giving a palliative treatment for the pain. So if you have migraine, you should use migraine-specific medications that treat the source of the pain, not giving something to eliminate or tone down the pain. They should never be the first, second, or third choice. And if a patient comes to you requiring or demanding them, they should be sent to an addiction specialist. I think the patients who are under physician's care should have a backup and emergency plan and something written from their physician that if they go to the emergency room with a physician contact and a plan. A lot of the times patients who go to the emergency room only get opioids because that's all they're used to using, and they think the patients are coming for that when in fact they're giving them the wrong treatment. One, start a preventive. Two, come up with a plan for detoxification and a way to cover the patients to cover the effects of detoxification and the aggravation of headache. Good care gives good results. Opioids are a shortcut that results in bad care.